Hello, everyone, and welcome to this next session on the role of digital transformation in learning health systems. I hope you've had a nice lunch, and I hope you enjoyed the sessions this morning. My name is Tim Horton. I'm an assistant director at the Health Foundation. I'm chairing this session. In a moment, I'll be introducing our speakers, but before I do that, let me just say something about the objectives of this session. It's really for us to explore the worlds of digital and learning health systems and the role that digital can play. The Health Foundation's recently been doing a range of research about learning health systems, and we want to share a bit of that with you today, as well as two of the really inspiring case studies we came across during that work. So I hope you'll enjoy the session. Without further ado, let me crack on and introduce our guests. So we're joined by Tom Hardie, a Senior Improvement Fellow at the Health Foundation. Tom has been leading that work I mentioned on learning health systems, and we'll be sharing some of that with you shortly. Nell Thornton-Lee is an improvement analyst at the Health Foundation, where she specialises in the use of technology and data in healthcare. Then we're joined by Martin Wildman, who's a consultant in respiratory medicine and adult cystic fibrosis at Sheffield Teaching Hospital, as well as being an honorary reader at Sheffield University's School of Health and Related Research. But for the purposes of today's session, he's here in his capacity as director of the Cystic Fibrosis Health Hub Learning Health System, which is supporting service delivery and improvement across more than 50% of the cystic fibrosis centres in the UK. And we're also joined by Ingrid Wolfe, who is Director of the Institute for Women and Children's Health and a consultant in paediatric population health at Evelina London Children's Hospital, as well as being a reader in paediatrics and child health at King's College London. And again, we've invited Ingrid today in her capacity as Director of the Children and Young People's Health Partnership Learning Health System, which is supporting health for children and young people in Lambeth and Southwark. And again, we'll be hearing a bit more about that work later. Before we move any further forward, let me tell you a bit about how we'll be using technology today in this session. So the first thing to say is that subtitles are available if you click on the live transcript button at the bottom of the page. And I think there will be instructions in the chat about that. Where possible, please have your videos on. From our experience, it makes it easier to engage in virtual conversations, but we ask that you stay muted, except for when you're in the breakout groups later, or of course, if you'd like to ask a question. This session's being recorded, or at least parts of the session. The breakout rooms won't be recorded, so I just want people to be aware that the session will be recorded. And finally, if you'd like to tweet about the workshop, please join the conversation on Twitter at the tag @theQCommunity and using the hashtag QEvent2022. So let me just talk to you about what we've got in store for you in this session today. In a moment, we're going to have a short presentation on learning health systems and the role that digital can play in learning health systems. Then we're going to move on to look at two case studies of learning health systems in action, the Cystic Fibrosis Health Hub and the Children and Young People's Health Partnership. Then there's a chance for you to reflect and discuss with your colleagues some of the questions that emerge from what you've heard. So we'll be having breakout sessions, and we'll be reconvening after that to take some questions and get some discussion going before we finish with concluding reflections and wrap up. Just before we kick off with the presentation, just to get everyone back exercising themselves again after lunch, I thought we'd ask you a question. And as you know, this session today is about learning health systems. I thought it'd be interesting to gauge how much everyone thinks they know about learning health systems. How familiar are you with learning health systems as a concept? Perhaps you could pop your answer in the chat. Just put a 1 if it's new to you or you're really just getting started with this as a subject. 2, if you're familiar. 3, if you reckon you are an expert. It'd be really helpful for us to know what level of familiarity everyone has today. So we're getting a lot of 1s, but some 2s as well. $1.5 to 2. Okay, so either we've got a lot of modesty here, or people are beginner or moving into a phase of more familiarity. So it's good to see a 3 there joining us at the end. Thank you, Tom. Right, thank you for that. Without further ado, let's get started, and I'm going to hand over to our first speaker, Tom Hardie. Over to you, Tom.
So, afternoon, everyone. I'm going to spend a bit of time talking about learning health systems, how they can help, and what role digital can play within them. And as Tim mentioned, I'm going to be sharing some of the findings of recent Health Foundation research on the topic. So why are we talking about learning health systems, and why are they gathering interest? And I think one big reason for this is data, which is increasing in volume and quality. And around 30% of the world's data is generated by healthcare, which is quite substantial. And this creates massive potential to generate knowledge and insights, which we can then use to drive improvements in healthcare. And we think learning health systems are a promising way to harness this potential. But what are learning health systems? So in essence, a learning health system is a team, provider or group of providers who, working with a community of stakeholders, has developed the ability to learn from the routine care it delivers and improve as a result. And a learning health system involves a learning and improvement cycle, which we've depicted here on the left-hand side of the slide, which typically involves 3 stages, which some of you might be familiar with already. The first one is generating data from service delivery, then asking questions and drawing knowledge from that data, as well as other relevant external data sources to understand service performance and the impact that services are having on their users. And then thirdly, putting that knowledge into practice and improving care through service changes. Now, thinking about the kind of drivers of a learning health system, at the heart of a learning health system is a learning community. And these are groups of motivated people that can include clinicians, patients, analysts, researchers, improvement colleagues, and others who come together around a common goal to identify problems and design and implement improvements. And we can see the common ambition representing that kind of common goal in the center of the diagram on the left. Next slide, please. But there's no single archetype of a learning health system, and they can really vary in their scale and in their focus. And this is something we really saw through our research, where we looked for real-world examples of parts of the country that are taking learning health systems approaches. And learning health systems can operate at different levels of the system, ranging from the microsystem or team level, all the way through to the national and international level. And they can also take a different focus. They can focus on a particular theme, for example, perhaps working to reduce potential harmful medication prescribing in general practice. They can also focus on specific conditions, for example, working to improve care for people with cystic fibrosis. We'll hear more about this from Martin, who leads the CF Health Hub. And then learning health systems can also be place-based, for example, working to improve the health of children and young people in South London. And Ingrid's going to talk more about how the Children and Young People's Health Partnership go about doing this in Lambeth and Southwark. And what you can see on the slide here is a number of real-world learning health systems examples that we identified through our research. And you can see here that each of these sit at a different level of the system and have a different focus. Next slide, please. So for anyone with an interest or background in quality improvement, one obvious question is, how do learning health systems relate to QI? Well, firstly, rather than something different and separate, learning health systems can be seen as the evolution of quality improvement. Learning health systems can be a way to embed QI as business as usual within an organization and put greater emphasis on data and analysis of that data. The continuous presence and centrality of the learning community that I mentioned earlier really enables improvement to happen over the longer term and help to go beyond a small number of isolated QI projects. And then QI can also play an important enabling role in supporting the design and implementation of service changes, supporting the work of the learning health system. For instance, PDSA cycles can support iterative improvement, which is really an important aspect of the continuous learning and improvement cycle that happens within the learning health system approach. So given that learning health systems can operate at different levels of the system, where are they most and least developed? Now, as part of our research, we surveyed stakeholders from across the UK on learning health systems to understand what the key challenges and opportunities are for developing learning health systems across the country. And we asked people how developed they think learning health systems are in different levels of the healthcare system. And as you can see at the top of the scale here on the slide, respondents told us that the most developed are learning health systems focusing on a particular condition or procedure. And this might partly be due to the availability of data through things like clinical audits and registries, and that also some health conditions have well-established and engaged learning communities. And on the other end of the scale, at the bottom here, respondents told us that the least developed are learning health systems across multiple providers. And in some ways, that's perhaps unsurprising, given that in some parts of the UK, the shift towards collaboration between providers, such as through integrated care systems in England, is a fairly recent shift. But this means they could have some of the most potential for development. So thinking about why they're useful, learning health systems can be useful in a number of ways. For example, learning health systems can give teams and providers the tools they need to diagnose and solve problems and drive improvement from within. Here, learning health systems can turn providers into engines of innovation and improvement that can generate new ideas and solutions, as you can see here on the left-hand side of the slide. One example of this that we think is quite a good example is the discharge to assess model, which was developed in Sheffield as a way of improving patient flow. For anyone who isn't familiar with this, this model involves discharging people back home or to the community and then assessing their ongoing care needs there rather than in hospital, which can have a positive impact on health and also reduce length of stay. Now, this innovation was created using what we might describe as learning health systems approaches, such as the creation of a multidisciplinary learning group and the use of data to understand the problem and define what a solution could look like. And success prompted them to think about how they could support others to generate innovations like this themselves. And you can see on this diagram how new ideas and solutions can be exported once they've been created. Turning to the right-hand side of the slide, learning health systems can also provide the infrastructure for teams and providers to adapt, embed, and refine ideas and innovations from elsewhere, creating what we might call implementation mechanisms. And as a result, learning health systems can play quite an important role in helping to deliver national priorities for recovery and service transformation. And NHS England are considering learning health systems approaches as a way to support the rollout of virtual wards at the moment. So as we've seen, learning health systems can vary quite substantially in lots of different ways. They can operate at different levels of the system and focus on different things. But from our research, we've identified that there are still some common activities that are present within most learning health systems. And in this slide, we've listed some of these common activities at each stage of the learning and improvement cycle. For example, starting at the left-hand side, generating data involves measuring outcomes and experiences, as well as creating and linking data sets. Moving around the learning and improvement loop, asking questions involves convening people, defining problems, and collecting views. And then analyzing data involves developing and deploying analytics, curating data, and understanding performance, and so on and so on. Now, given that most learning health systems share these common activities, we think that one way to support the development of learning health systems is to focus on how to do these activities well and effectively. So thinking about what learning health systems need, what do they need to do these activities that I mentioned well? Our research showed that learning health systems require some key things to function effectively, which you can see on the slide here. And while they're all important in their own right, they can also support the process of continuous learning and improvement. So starting with data, analytics and research. But these can be critical because they help services understand how they're performing and identify where improvements could be made. And this relies on having high quality representative data that's timely, easy to access, and in a format that can be analysed. And then it also requires specialist skills and knowledge to curate and analyse that data. Technology can help learning health systems by enabling the capturing and interpretation of data, and also supporting the direct delivery of care. And this requires things like the right underlying infrastructure to support the use of technology and the right skills and tech literacy among both staff and service users. Learning communities on the bottom left here drive the efforts of the learning health system by deciding what problems to focus on, identifying improvements, and putting those improvements into practice. To function effectively, these communities require things like trusting relationships, mechanisms for collaboration, and of course a learning culture, which we talk about a lot and we know is important. And our research showed that learning health systems are not only technical, but deeply social as well. And so learning communities, which lie at the heart of the learning health system, really need to be nurtured carefully. And then finally, putting improvements into practice is also critical, because ultimately the ambition of the learning health system is to make services better, whether that's by delivering better outcomes and experience for users or improving efficiency. And this can be supported by quality improvement skills, as I mentioned earlier, but it also requires the time, space, and resources to implement changes. So to finish, I wanted to explore the role of digital in learning health systems in a bit more detail. And through our research, we found that while you don't necessarily need digital technology within the learning health system, we're increasingly seeing it play an enabling role, particularly because of the intimate link between some of these technologies and the capturing and use of data. So just thinking about some of these roles here. Firstly, digital technologies can enhance the way data is collected and analysed, and we'll hear from Martin shortly about how they've done this within the CF Health Hub. For example, devices such as smartphones, wearables, and sensors can support the collection of real-time data that helps the system understand how it's performing, and also support decision-making on an individual level for service users and clinicians. And then technologies such as artificial intelligence offer promise in supporting the analysis of these data to help the learning process. Digital tech can also provide access to high quality information. So, for example, electronic health records have the potential to ensure the right information is available at the right time, that can then help frontline teams to make decisions about the care they're giving to individuals. Collectively, electronic health records can provide information about the health of populations, showing what services and support are needed. We'll hear a bit more from Ingrid about how the Children and Young People's Health Partnership uses a wide range of data to address population health. Digital tech can help with clinical decision making. So electronic health records can be combined and enhanced with other digital tools like clinical decision support systems. And these systems can then match an individual's health record data to clinical knowledge to create personalized care recommendations for clinicians to consider as part of their decision-making process. And then finally, digital technologies can also support the design and implementation of improvements. So digital communications tools ranging from research platforms such as Discovery, which is led by the Healthcare Improvement Studies Institute at the University of Cambridge, and also online collaboration spaces like Future NHS can enable the sharing of ideas, evidence, and solutions. And then they can also help to bring stakeholders from diverse backgrounds and geographies together to collaborate, discuss ideas, and design improvements. So, although that's not all of the opportunities that digital technologies can bring within the learning health system, I think that hopefully gives you a flavour of the role that they can play. I'll hand back to Tim now for the next part of the session.
Thank you, Tom. That was a really helpful overview of the concept of learning health systems and why they're useful, as well as some of the specific issues with the role of digital in learning health systems. And really that helps set the scene for the next bit of this session, which is really designed to give you the opportunity to hear more from two case studies the Cystic Fibrosis Health Hub, and the Children and Young People's Health Partnership, who are using learning health systems approaches in practice. Both of these were case studies in that report I mentioned at the beginning that the Health Foundation's recently published. And we're delighted today to give you the chance to hear more from the people leading them. So we're going to spend about 20 minutes or so hearing about these real life examples of learning health systems and the role that digital is playing for them. And then we'll be reconvening to give you the chance to reflect and discuss what some of what you're hearing means for you and your work. I'll be handing over to Nell in a sec, just to say, if you're having any issues with tech, please message us in the chat and we'll do our best to sort it out, okay? So without further ado, Nell, over to you.
Well, thanks, Tim, and hello, everyone. So I now have the pleasure of being joined by the directors of two of the case studies featured in our latest report, Ingrid Wolfe and Martin Wildman. And we're going to explore learning health systems in action, and I'm going to pick their brains on the role that digital technologies have played in them. Martin is the director of the Cystic Fibrosis Health Hub. That's a digital learning health system that's optimizing outcomes for people with cystic fibrosis by creating a national community of practice that's using data to improve care. And I'm also joined by Ingrid, who's the director of the Children and Young People's Health Partnership, which is a population level learning health system, which is delivering better care and better health for children and young people in South London. So Martin, I'm going to pick on you and come to you first. So to get us started, do you want to just tell us a bit about the CF Health Hub? What was the challenge that you were looking to address?
Thanks, Nell. Thanks for inviting me to talk to you today. So the problem that we were hoping to get to grips with was the fact that 7 out of 10 pounds of the health and social care budget is actually spent on long-term conditions. And one of the characteristics of long-term conditions is that people with long-term conditions often self-manage 365 days a year, but actually touch the clinical team relatively rarely. So most of the action in optimizing long-term conditions is out of sight and out of mind. And within improvement science, I think one of the things that we all know is that improvement comes with attention. So how do we pay attention to what is out of sight and out of mind? So that's what we were doing. And we were concentrating on cystic fibrosis as a condition that's primarily is an archetypal long-term condition, primarily looked after in a relatively small number of tertiary referral centres with a care pathway that is manageable, with the aspiration that a modest investment of funding, in our case about 8 to 9 million, could potentially optimize that care pathway. By doing that, we could create an exemplar which has the potential to create vicarious self-efficacy for other researchers trying to optimize more difficult long-term condition care pathways, like, for example, asthma. So that's what we were up to.
So you've mentioned kind of the size of the problem. How did you get started? How did you know what to do first?
Yeah, so in your monograph, you highlight the fact that the Flow Academy is part of the Sheffield Teaching Hospital setup. So we had within Sheffield a very strong improvement heritage using microsystems. So we started where people typically do start in optimizing complex systems. We started with flattening the hierarchy. So creating psychological safety by having a facilitator sitting within our team and talking about the 5 Ps, so processes, populations, and within that, purpose. What was our purpose as a CF team in looking after people with CF? And we concluded after a number of weeks of backwards and forwards with a hierarchy flattened and the information coming up from the whole team that our purpose was to enable people with CF to live as normal as possible. And as is often the case in long-term conditions, we oscillate between prevention, which enables people to stay in the community but be part of the frontline team, and rescue, risky hospital admissions. And we realized that in order to enable successful self-care in the community, we needed to empower prevention. So that's how we started, and we started to realize our destination. So, as if we've got the other side of the river, we've got a series of stepping stones. The other side of the river was successful preventative self-care. So patient activation, knowledge, skills, and self-efficacy. So that's where we started.
Fab. So we talked about in the case study in the report about the role that technology played, and Tom has talked a bit about how digital technology can support learning health systems. Do you want to just tell us a bit about how data and technology played a role or plays a role in your learning health system? Also, how did you select the best technology? How did you know which one was the right one to embed in that process?
Yeah, so those are really good questions. And just to say, we use this is complex. So we use a series of thinking tools. One of the thinking tools that we're really quite keen on is Trish Greenhalgh's NAS framework, which allows us to think about the fact that our problem is moving complexity to complicated to simple. So when it came to using technology, we were not obsessed by technology, we were obsessed by behavior. Our behavioral destination was to create habits, because habits are a form of simplicity from the complexity of managing a disease without habits. And what we wanted to do was have detailed, real-time data about how people got on with the habit of taking inhaled therapies to keep their lungs healthy. So we sought a data capture mechanism that would allow patients to provide passive data capture. So all they do is get on with their lives. The data is automatically captured. It then comes back for us to use to support them. And the way that we did that was we had a NIHR program grant, so a couple of million over 5 years, and we spent the first 14 months co-producing a data sharing system, co-produced by clinicians, because we need to equip clinicians with knowledge, skills, and self-efficacy to do something they're not used to doing, which is supporting prevention. And we did the same thing with the patients. How could that be used by then? So it was actually, the selection of the technology wasn't difficult, because there was actually only a couple of providers who could do it, and only one that could do it with digital data capture via the cloud and back to the patient. So actually, our tech selection was relatively simple, but the priorities were passive and simple. In the end, we ended up with complicated, because we had data capture that involved something plugged into the wall that sent the data to the cloud with low power Bluetooth. So there was an element of one step in the chain, and that's what always fails. So we have, using the NAS framework, worked to make that simple, and we're shortly to introduce a data capture system where there is no link in the chain, it just goes straight to the cloud. So again, we encountered complicated, we went to simple, we've modified our tech. Hope that makes sense.
Yeah, absolutely. And I think you make a really important point around co-design and co-production, and making sure that the people using the technology are part of choosing it and embedding it, because they're the ones that are going to be using it. And I think there's an important point there around not starting with the technology, not saying, hey, we've got this great thing, how do we put this in, but start from, where do we want to finish, and can technology fit into that? I think that's a really important point as well.
And Nell, one other thing there is, we believe this is a complex intervention. So we find the MRC complex interventions pathway very informative. And what the MRC complex intervention pathway says is you should have a coherent conceptual framework. So we had a coherent conceptual framework that was about behavior change. It was about habit formation. So the tech was chosen in order to enable our coherent conceptual framework to create habits. So the tech very much came after our coherent conceptual framework. And because our coherent conceptual framework was behavior change, it was COM-B, and COM-B modified for habit, because habit, of course, is a simplification of a complex behavior, which is back to another thinking tool, NAS.
Bro. And as well, I think you made a really interesting point around, with the tech, starting with the principles of what you need that tech to do. We need tech that can do X and Y, not we need this bit of kit. And then once you've embedded it, you can build on that and then make it easier or more complex, depending on how that's being received. I think that's a really, really interesting point. So my next question is around the CF Health was established to kind of help people with cystic fibrosis manage their conditions, but we talk in the case study about how you've been able to use the structure that you've built through the learning health system to test other new innovations and treatments. Do you want to just tell us a bit more about that?
Yeah, and as I do this, again, to be slightly boring, I'd like to come back to systems theory. Simple, complicated, complex. So what we had was a data capture system that was around gathering information about self-care. We were inundated with people wanting us to add step counters, physio measurement. We didn't want to do that because that would have diluted the attention that people were able to give within our system. So we stayed with optimizing adherence, but we still did things. So we created Embrace, easy medicines for burden reduction and care enhancement. So that was a medicines optimization module. And what it did was, we knew that the amount of drugs that people collect from the chemist was 60% of their annual prescription. We knew that 30% went into the lungs. Therefore, we knew there was about £50 million worth of waste. By doing just-in-time drug delivery, which was Embrace, we were able to save 50 million, which will pay for the platform, but also enable patients to get just-in-time delivery of their medicines. So that was staying within the tech we'd got. It wasn't diversifying, it was using that data differently. One of the other things that happened during this program was Kaftrio, which is a very effective CFTR modulator, so a drug which makes CF a lot easier to look after, that came in. But we knew from history that the first of those modulators lost its effectiveness after 5 years. So we had the hypothesis that that was due to a lack of co-adherence to inhaled therapy. So even in the middle of lockdown, because our patients had given trials within cohorts consent, we were immediately able to recruit 1,000 patients to do a real-time health technology assessment of the new drug. So that was, again, same data set, but used to leverage very important questions for patients. And then thirdly, within all this, we worked with NICE to create an equity framework so that we could understand which patients who were eligible to use CF Health were actually using it. This whole issue of digital equity is important because unfortunately, if we're not careful, we love the tech, we pay attention to the people who are on the tech, and the people who are disenfranchised by not on the tech do even worse. So the NICE indicator was another way of leveraging the same information, referencing back to the CF register, which gives us denominators, to understand the reach and engagement of the platform. So one platform, a number of modules, but all the modules very much related. And the attention that we pay is actually the attention around the same metrics, because otherwise we dilute the attention and we don't create change.
Yeah, that's a really, really interesting point. And I think speaks to the ability of, having a learning health system that's generating information and generating insight. It's not just about feeding that information back into that same loop. Actually, you can take those insights and apply them in other areas as well, and kind of have simultaneous improvement going on.
Of course, we should always be doing PDSA cycles. We should always be getting better. So at the heart of this is PDSA cycles work towards optimization with a very clear idea for everything that we do. What's the other side of the river that we're trying to get to? How will we know? So the metrics, what are the metrics? How will we know if we've got there? Are we collecting the right data? Are we actually changing? So we have a community of practice. They meet every Tuesday. They look at the data. We look at the problems that we've got and we work together. So it's that continuous improvement driven by data, but actually always focused on how do we get better. And our aspiration is to enable people with CF to have a normal life expectancy. And that just drives everything we do. That's the other side.
Brilliant. Thanks so much, Martin. Big message there. Goal first, technology second. I think sort of taking from that. And thank you so much for those brilliant insights, Martin. And for the people with us, if Martin has said anything that's inspired you or triggered some of your own reflections or questions, then do scribble those down as we're going along, and you'll have some time later to talk more about those, think more and ask some questions. Thanks again, Martin. I'm going to turn to Ingrid now. So Ingrid, I'm going to put the same first question to you that I put to Martin, which was, tell us about the Children and Young People's Health Partnership and what challenges you're seeking to address.
Yes, hi, and thank you ever so much for for featuring us as a case study. It's delightful to see so much work being recognised and hopefully providing some value. And if nothing else to save people having to go through some of the difficult steps in the early days. So it's a real pleasure to be here and talk with you. So thank you. So similar to what we've just heard from Martin, our start point was about fixing a problem with health. And so I've been preoccupied for a very long time with what's going on with child health outcomes, really at national level. Why are we so much inferior to other countries, and what can be done to fix it, at least within the health system? There's quite a lot in policy that needs to be addressed, but I'm thinking really in the health system. So within that domain, what can we do to improve child health outcomes and to do so at scale? So, so there's some high-level outcomes that are worrying and can be better. But then if you think about what the solutions might be, we know that there are problems within the health system to do with the relative balance between the focus on acute care, which is of course essential, but also how do you start to shift away from what we call a sickness service, or what politicians call a sickness service, towards a health service? How do we actually do that to really improve outcomes, not just fix problems as they come at us, but try to really move things in the direction of health promotion and disease prevention and improving planned care. That requires much better use of data and to sort the system out. So how do we achieve that early intervention was one of the first problems that we were thinking about. Now, of course, there is a huge policy priority on so-called integrated care. You hear a little bit less about it now, but it's nonetheless a major stream within the long-term plan of the NHS. It's very intuitively sensible, but it lacks evidence. So that's another strand of what we were interested in. We were facing the challenge trying to deal with the lack of evidence, good evidence for solutions. And so I'm very taken with the approach that you've alluded to, and is kind of a running theme within the Health Foundation and beyond, is how do you take quality improvement and marry it up with health services research and good evaluation? And so that was another problem or challenge that we were trying to face. And so in designing our solution, we did the same thing that Martin mentioned, which is to use the MRC guidance for complex intervention and embed that within a learning health systems approach. And so one of the other challenge, kind of to get more specific about learning health systems, is better use of data and evidence for healthcare, better use of real world data, routinely collected data, and how do we embed rigorous evaluation and health service research into quality improvement, hence the learning health system appeal.
Excellent, thanks Ingrid. So you've mentioned around the importance about better use of data and kind of real world data. Tell us a bit more about what kinds of data does CHIP use, and how does technology help you to get that data and analyze it?
Yeah, well, the first thing that we discovered is that there wasn't as much routinely collected data that was useful as we had wanted. So we thought then about what can we do to make better use of the routinely collected data and augment it with all of the other sources of data that are available, and then what do we need to do to collect more? So like Martin, we do collect some specific data. So the way I like to think about it is in several sort of layers. So the data, first of all, is patient entered. So children and families use a patient portal to undertake or to do a biopsychosocial pre-assessment. So we ask them a bunch of questions, and so the technology is a patient portal or an app, and we contact them first, and we use the population registry that is a GP record. Basically, we know all the patients who live in an area that have a particular set of situations or conditions. You can define it however you like. So for example, all children with asthma, we can contact all of them. So we have a stable denominator, contact all of them, and then they click on a link and that they get in the same way that you would from your GP for screening or immunization or whatever else. Click on a link, takes them to the portal. The portal is about collecting data. The portal also is about giving information back, health promotion information, and that loop is really important. So we have patient-entered data, we have the health service use real world data, poverty, air quality, prescriptions, contacts with the health service, and so on. The final layer is research data. So how do we make better use of trials that are related, where we can access and use data that will help us better to not plan individual level care, but to plan what we do as a service. So then just to turn to the technology, there's the patient portal, which I mentioned. Next steps on that are to go to apps and wearables, and we're pretty much in that space now. We're just about to start a trial. We're in setup phase now on testing new technologies to augment that. So smart inhalers, for example, for children with asthma, or this clever little wheeze detecting device. It's a little microphone that you can stick on your child's throat to help you understand what's going on in terms of the respiratory sounds. And how do we plug that into our learning health system? The other important part of technology is the ability to be able to join up data sets and to join up clinical notes, because it's really important that there is a good clinical response to the information that you're gathering. What do you do with that information? How do you use that data to solve the problem for the patients and also the population? So being able to deliver a model of care that goes across sectors or across organizations and uses technology to augment that is really, really important. And there's a bunch of quite interesting stuff that's coming out of that now, not just data dashboards, but geospatial mapping and predictive modeling that helps us go from technology and data collection through to processing and analyzing that and presenting back to patients, to decision makers, to clinicians, that information in a way that really supports decision making in a clever way.
And this sounds like really innovative ways of collecting lots of different information that goes beyond just people's kind of, traditional health information. So there's a risk sometimes when you have all these ways of collecting data that you can be overwhelmed by the amount of information that you have. How does your learning health system help you turn all of that information into insight, into an action?
Yes, well, so it's exactly the point I was trying to make or introducing, is that you have to have a response. No good just getting all of this data. It's quite true, it is complicated, but how do you turn that into something that is actually translated into benefit for patients that you can measure and evaluate? So the way we do that is in sort of 3 layers again. The first one is clinical. So this is the model. So we've set up a local child health team, and there's 1 per primary care network. And that's a sort of a population size that is quite useful for a team to make decisions for a population. So we have a local child health team, which is a multidisciplinary thing. And we look at all of the data that comes in. So we get a spreadsheet with these many patients to look at this week. We see all their biopsychosocial pre-assessment data. We know whether they've gone, spending all their time coming up to A&E or whether they're being seen in primary care and what that balance looks like. We know whether they're picking up their prescriptions for preventers or they're not, things like that. And that allows us to triage care, first of all, like everything's fine, don't need to do anything, or needs to be seen soon, needs to be seen now, that kind of triaging. But also really important, that personalization. So tailoring care at the individual child and family level according to what we've learned through the data. So for example, we know if a child has unmet needs for asthma care, so is their asthma poorly controlled? We now know that. We know if they have concomitant multimorbidity, which is usually something that's talked about in the older population. We know whether a child has got lots of anxiety and depression symptoms along with their asthma, so that we're dealing with the whole child, not just the disease. And then we also know what else is going on at home. Now, primary care is very good at doing that. And so what we're trying to do is build on that, because we know what's going on with the family. So we got some data from the biopsychosocial assessment about the challenges going on for parents. Is there parental mental ill health? Is there housing insecurity and food insecurity and all of this sort of stuff that really impacts on that child's holistic well-being, so that we can respond in a way that is cognizant, again, as I said, of the whole child. Now, what we can do with all of that very granular individual level data, as we keep doing this, and we've run this now many, many cycles, is that we can start to build up a population map. So we know geographically where there are areas of greater unmet need than others. And so we can direct our early intervention efforts more to areas of unmet need than to areas that might shout louder, but actually have lesser needs. So that population impact is really important, but that's sort of a more advanced step, and you have to have done what you've done for the individual patient quite a lot before you build that up. But that's the direction of travel, population health planning for for patients. And then finally, there's the research bit. So actionable insights from research are really important. So measuring the impact of what we've done in a research rigorous way and plugging that back into how we continue to evolve and improve the model.
Excellent. Thank you so much, Ingrid, for that. That's really, really insightful. I'm sure we could talk all day about this. Unfortunately, we have run out of time. Although there will be no, it's not you, it's brilliant stuff. There will be an opportunity for people to reflect and ask questions, so I'm sure they'll come back to you again. Thank you. So Tim, I'm going to hand over back to you now to take us through to the next part of the session.
Many thanks, Nell, and thank you very much to Martin and Ingrid for sharing their work with us. So now there's a chance for you to reflect on what you've been hearing and discuss it with the other participants here. In a couple of minutes' time, we're going to be putting people into breakout rooms where you'll have about 12 minutes to have smaller group discussions with your colleagues here. We'll be moving you into those rooms automatically and you'll be moved back, so don't worry about that. And it's a chance really for you to reflect on the relevance of the issues we're talking about today for your own work, and the questions that might be emerging for you about this as an area, as well as any questions, of course, that you'd like to ask our speakers when we reconvene. But before we move into those breakouts, we wanted to give everyone 2 minutes just individually to jot down some thoughts before we move you into breakout rooms. So what I'd like everyone to do is to take the next 2 minutes to start reflecting on and jotting down thoughts they've got on what you've heard so far. And in 2 minutes' time, I'll be coming back on to signal that we're about to move into those breakout rooms. Okay, so here you go, 2 minutes. Welcome back, everyone. I know people are returning from the breakout sessions now. Just to explain what's happening next, we've now got some time to share reflections and ask questions. We've got Tom, Ingrid and Martin here to answer any questions you've got. If you have a thought you'd like to share or a question you'd like to ask, please either raise your hand, which you can do under the reactions menu in Zoom, or post your question in the chat and we'll pick it up. I am, though, going to start by abusing my chair's prerogative to ask Martin and Ingrid a question. And that's this. Really inspiring to hear about your work. How on earth do you find time for it, is my question. I mean, services are under such pressure at the moment. People are under such pressure. How do you find time for it? And is it a tough gig to persuade other people to take part in this kind of work?
So that's a really great question. And interestingly, this morning I was doing a talk for the Flow Academy in Sheffield, which is our improvement organisation, and this issue came up. And if we go back to Donna Bedian's framework for improvement, structure, process, outcome, and we add balance to that, of course, structure is utterly crucial. And very often, one of the structures is the time to pay attention. So this is not resource neutral. One has to find the time. So how did I find the time? Well, I was a full-time clinician. I got up at 4 o'clock every day for a year to write an NIHR program grant. And then I bought out some of my time during the program grant. Now, actually, I'm not paid on a Friday because I can't find anyone to pay for the time I need to do the work. So it's really, really difficult. And even when you've created an intervention, the path from that intervention being created to the implementation is very difficult. So the AHSNs are really good at connecting you to VCs for something that solves esophageal cancer. But actually, for things that optimize pathways, where the money that is saved probably sits within the structure of the hospital and might well actually be written off as P&E, it's so much more difficult. And I actually think that as an improvement community, we need to really pay attention to the importance of prioritizing this kind of pathway improvement because it's utterly crucial. but it's not resourced. We spend billions on creating a new drug, but we do not create billions on optimizing the pathways within which the use of that drug sits. And so I think as people who are active in this area, who have fought to gain the skills, we should be engaging with policymakers about the fact that this matters and that the resources need to accompany good quality work because it makes the health service affordable. So important.
Yeah, I couldn't agree more strongly, actually. It's absolutely what it's about. And like you, I struggled to get funding and had to get up and work weekends and all the rest of it. It is not easy. We had slightly different and interesting challenges. We formed a local partnership, and that I think that was really helpful. It's with clinicians, decision makers, and academics. And that was very helpful because we had all the right people around the table to make decisions. And that was very, very important. Everybody was bought into fixing the problem, and the problem was about health outcomes. And so that was very important. And it was also really about hearts and minds. So people, because you're right, it costs time and it costs effort, and it means trust is needed. And it means working with people in different organizations, and all the financial incentives don't align and all the rest of it. So having a partnership board where governance is shared, where decision-making is shared, where people are bought into the problem really, really mattered. It is expensive in terms of time and money. So to test a new model of care, we had to double run with the old model of care. And that requires a lot of investment. So we got charity funding for it. Interesting what you said about an NIHR program grant. I went down that route also and then completely changed my mind. And the reason I did was important. And apropos what you said about the use of evidence for testing a technology or a pharmaceutical intervention compared with a health services intervention. What happened was that the partnership group were completely convinced about the value of embedding this model without testing it. And so they were not in the least interested. They were happy to pay for embedding it. They were happy to pay a little bit for evaluating it. They were not happy to wait for the time that it would take to do a program grant. Not interested in it. They were quite persuaded by the evidence of a problem and quite persuaded with the logic of a solution, not testing it. We're not interested in doing a trial. And it took a long, long time to get to do that. So in the end, what we did is we double ran an evaluation. We did a service evaluation for them, speaks their language, reports in their timescales, gives them the metrics that they need for making decisions. But because we live in such an evidence light zone, I wanted to run a cluster randomized controlled trial at the same time. And so we managed to do that, but more as a kind of invention, through necessity, rather than I didn't set out to do that. It was clunky and difficult, but I was so sort of committed to building up some health services research evidence. But we still have that problem where it's difficult to get focus and attention on things that are not about technologies in the way of, or fixing a disease problem or molecular approach to this particular, that kind of thing attracts lots of attention. Health services research, less so, alas.
Great, thank you. Now, the first question we have in the chat, well, a comment from Tom Rose, starting on a small scale seems like a good idea. It would be good to get your reaction to that. And I suppose the broader question there is about getting started. What someone else out there was going to try this kind of work, what advice would you give to them as they got started?
So,
Want me to have a go?
Yeah, you have a go.
Okay, so I do think there's some benefit in starting at a smaller scale than what we did. So if I was going to go through it again, I probably would focus a little bit more than what we did. We did a very large health system strengthening intervention. I'm very committed to a population approach to health. So I wanted to do something that was about large numbers of children, that Jeffrey Rose prevention paradox, right? So I really wanted to focus on ordinary, everyday problems that affect large numbers of children rather than on rare conditions that attract attention. So that meant looking at an at-scale intervention, and that's hard to do. So I think I would have started with like a condition or a specific group first and then built it up from there.
Thanks, Ingrid. Martin, any reflections?
Yeah, so I mean, I think that all of us probably within the improvement community are very committed to PDSA cycles. And so to actually do a PDSA cycle and then scale up is a absolutely appropriate way to move forward, isn't it? So yeah, starting small with PDSA cycles and then iterating and increasing the size is a absolutely fantastic way to move forwards. I think that exemplars can be helpful, because if we do have successful exemplars, that can make the case for adequate resourcing, whatever size of approach we start with.
Great, thank you. So we've got a couple of questions here from Jem Ramazanoglu. Let me pick one of them. Martin, Ingrid, could you tell us a little bit more? What's the role of digital technology in enabling the capture and sharing of learning?
Okay, well, I'm happy to start with that. So I think that what one probably is wise to do is understand the destination of your complex intervention. And once you've decided what the destination of the complex intervention is, which sort of metaphorically is the other side of the river, we've got a series of stepping stones across that river. And we've got metrics that matter that enable us to understand whether we are moving towards our destination. Tech is a very good way of populating that journey with the metrics that matter. So you start, I think, with the destination. You have a conceptual framework that gets you to the destination. That gives you some key bits of data that tell you how you are getting on in reaching your destination. And then tech is a great way to get that data. So that will be how I would foresee tech sitting within the framework of learning health systems. Learning health systems are not a way to showcase tech. They are a way to improve care. And that is the destination, and tech might be one of the tools that you need to achieve that. That's the way it seems to me from our experiences.
Thank you. Ingrid, any thoughts on that?
Yeah, I fully agree. I'm just going to reiterate it really, and just to say how valuable it is to be able to demonstrate improvement and learning, and in a very clear way. So data visualization through technology is really important. Yeah, so I think demonstrating tangible demonstrations of improvement and the ability to support better decision making through data acquired through the technology. So yes, I think it's absolutely crucial.
While we're on tech, let me just ask, because both of you, the nebulizer, Martin, stuck in my mind in your example, and Ingrid, the portal, the patient portal in your case. How do you land tech with patients and the use of tech? Did you find that easy to do in the work you're doing, or did it require work and special strategies?
Well, for us, what we did is we just built on what's already done in public health and in primary care. So the screening and immunization technology, the fact that we use this thing called call recall. So you look at a GP list of patients, you have a population denominator, you can send text messages to them all. That's already done. So we managed to negotiate a system whereby patients would receive a text message, not from us as sort of a new thing, but from their own GP. And so we were very much embedded in the system. They receive that text message just like they would for anything else, with a link just like they would for anything else. That takes them to a portal, and they don't have to worry about what the technology looks like. We did worry about the digital divide, and so made sure that we had backed that up with other ways of engaging with people. But otherwise, it wasn't too difficult to do that. And then where we've gone from there into sort of, making sure we send health promotion back and testing digital technologies, smart inhalers and so on, that's actually been not too difficult. People are quite keen to engage with intuitively straightforward technologies in our experience.
So Tim, we found this a really important issue. What we have found in cystic fibrosis as a long-term condition is that actually, when we use PPI to engage with people with CF, we often engage in a way that's very much non-representative of the whole population. And actually, the people who are most at risk of dying from long-term conditions or coming to a great deal of grief with long-term conditions are often not the people who populate your PPI panels. And we found that very many people with CF absolutely want to ignore their CF. So therefore, our offering took account of that. Our offering was, give us some time to engage with some tech for a short period of time so that we can enable you to build a habit of self-care. That habit of self-care will make your treatment taking invisible. By taking preventative therapy, your CF will become invisible and you can forget about us. So we were absolutely about making the tech, from the perspective of the patients, utterly invisible once they had actually spent some time with us. And the theory there was, give someone a fish, you feed them for a day, teach them to fish, you feed them for life. So the whole point here was that we build the ability for them to build habits, then build those habits again as their context changes, with the tech only being a temporary aberration in their lives. Because I don't think that people with long-term conditions, it is healthy for them to be obsessed with that long-term condition. What you want to do is give them the ability to self-manage without having to have their mind constantly filled with what it is to have a long-term condition. Now, the clinicians are different. The clinicians do need to pay attention to it. But the way we do that is we put it in the job plan. So somebody has the job of opening the data in the multidisciplinary team meeting within a schedule with the data actually organized. And you pay someone to do that, because if you do that, then your system becomes better. So we have different strategies depending on who's using the data. From a patient's perspective, we really don't want them to dwell on their data. I hope that kind of makes sense.
Yeah, very much so. Thank you. Thank you, Martin. Next question from Penny Pereira, who says, given this takes investment and time, how do we avoid spending too much resources on developing the data at the expense of service change? I mean, I suppose, just to step back, is that a risk you found in your work, that a huge amount of focus is on developing the data and the robustness of that, and it almost becomes an end in itself at the expense of other important objectives?
So I'm happy to answer that, give a perspective on that. Absolutely. You've got to ask yourself, what's your destination? Your destination is not fancy data. Your destination is not that. For us, our destination, I'm a clinician. So when I get it wrong, I'm actually up on the ward looking after someone who's super sick. So for me, there is one destination. The destination is to enable people with CF to live a normal life expectancy, and now to give them normal life expectancy. So that's the objective. And actually, I'm brought back to earth every time I do a clinic, and that's not happening. So yeah, it's important not to get intoxicated by the process. The outcome is crucial. You have to pay attention to the process. And you do have to resource someone who's slightly geeky and interested in that stuff to do it. But that's okay. I always think that optimizing anything is a team game, and you've got to have different people in there with different perspectives and different skills. And probably I'm a bit too geeky to do really good patient support. But that's okay, because there'll be someone in the team who can. So I think it's that total system with an absolute and unshakable view of the destination, which is an NHS which enables people within our community to live as well and as long as possible. That's our destination. And within that, you're going to have people who just love data, and that's fine. Have them in your team and let them do that bit.
Thanks, Ingrid.
Yeah, just to add a little bit to that. So I fully agree that destination has to be about improving health. I would do that in two ways though, and the balance is absolutely crucial. So the most focused balance has to be on improving outcomes. But I'm very committed in a quieter way, but nonetheless no less focus on the research side of it, for the reasons that we mentioned before, in that if we continue to do this really great quality improvement work only in a local way without evaluating it properly, we're going to have to keep doing it in a sense. So I want to be able to spin off the learning through doing really good evaluation, so that we can continue to drive those outcome improvements elsewhere, as well as where we are. So both, and inevitably there's a balance. It can't just, in fact, it's one of the really interesting cultural divides, in that, and one of the reasons why I didn't pursue the program grant is because honestly most of my colleagues at the outset thought that it was a kind of an add-on luxury to do a proper evaluation and research, and that it wasn't essential and germane to the focus. And I don't agree, but I do agree it has to be practical and it has to be very patient focused, and it should not be ivory tower. So the balance is the key to me.
Brilliant.
Totally agree. That's such a powerful rejoinder to what I said. Yeah, totally agree.
Thank you. In a minute, we're going to have to move on to the final reflection of this session. Before I do, just to say, Jem, sorry we didn't come to your other question on quality management systems, and thank you, Tom, for the link you've posted on that. If anyone's interested in the report that the Health Foundation has done that I mentioned, we do think briefly about the relationship between the two. For us, Learning Health Systems is a great vehicle of quality improvement, and by providing a way of doing that, approaching that more systematically, potentially makes it easier to join up with those other aspects of the quality management system: quality planning, quality control, and quality assurance. And I know some leading organisations like East London Foundation Trust, who are choosing to take a single approach to all of this, are kind of providing, quite useful insights on the way these different elements can be brought together. So do have a look at the report if you can. And sorry we didn't have time to take that question. Now, for the final bit of the session, we'd like to ask you guys for some brief reflections. Specifically, we'd like you to reflect on the two questions we've got in this slide here, which you can answer using the chat function. Something that stood out for me through this session is, and if a thought springs to mind, I will apply this to my work by ... So please post any thoughts you've got in the chat. We've got a few minutes for those, and we'd just really like to hear from you what you found useful and how you might be able to apply it. You've got 2 or 3 minutes to think of answers to this, so please take the time and do that. Shortly afterwards, we're going to be moving to an evaluation poll quickly, where we'll ask for more feedback. But I'm just going to shut up and give everyone the 2 or 3 minutes I promised to reflect on these 2 questions and post things in the chat. Thank you. I'm really enjoying these reflections. Please keep them coming. Really interesting thought there from Tracy. In addition to learning health systems, think about how we learn and collaborate across them and the potential there. I think that's where things like the Q community really come into their own as a vehicle for helping bridge these different kinds of work going on. One more minute. Look, thank you to everyone who's posted there. Fantastic to see those reflections, and actually they're more than reflections, really provoking thoughts for others to take away as well. So thank you so much for that. In a moment, as I said, an evaluation poll is going to appear, and we're going to ask if you could just give a couple of minutes to reflect on that. But before that happens, it was great to see a couple of comments in that chat, people saying they'd like to find out more about learning health systems on the back of today's event. Well, there's a lot about learning health systems out there, but it would be remiss of me if I didn't plug the report we've recently published on that. You can find that on our website, and please do take a look. And of course, if you'd like to get in touch with us, you can get in touch with us on social media, the details you see there, or directly at the Health Foundation. Before we move to the poll, I just want to say a big thank you, firstly to Martin and Ingrid for joining us today to share their work and their wisdom, and to Tom and Nell for presenting the Health Foundation's work. And of course, thank you to all of you for joining us for this session today. I hope you found it stimulating and useful. And just a reminder, we've got a poll to come now. Please just take a minute to fill it in. Otherwise, thank you and enjoy the rest of the day.